This is the University of Hawaii Maui College, the college on Maui.
We're going to go through some basic pharmacology concepts. Pharmacology is the study of substances that interact with living systems through chemical processes, especially by binding to regulatory molecules and activating or inhibiting normal body processes. And that comes straight from my predecessor, comes straight from Kat's song. Most drugs interact with a molecule or protein that plays a regulatory role in living systems. The point here is the drugs we use to affect the body are working on systems that are already in place regulating the body. And so what we want to do with drugs is manipulate existing regulatory systems in the body. And that means drugs must have specificity. We can think of a drug as like a key, and we can think of its receptor like a lock. And not any key fits in any lock, and not any drug is going to fit on any receptor. And so drugs must have specificity to interact with that receptor. So drugs that interact with receptors must be the appropriate size, charge, and shape to interact with any given receptor. Drugs got to get there to work. That's been said longer than I've been here. A drug must be able to be transported to the site of action. If you took the drug and it stayed in your stomach and stayed in your small bowels and passed through your colon and out into the toilet without being absorbed at all, then it would certainly not be able to be delivered. And so drugs got to get there to work. And then drugs must be removed at a reasonable rate as well. It makes no sense to take a drug and have it stay in our body forever. And so drugs must be removed and excreted at a reasonable rate. And most drugs are weak acids or weak bases. Sorry for the fine print. And that's where pKa comes in. pKa is the pH at which the molecule or drug is balanced between the uncharged form, which is the lipid-soluble form, and the charged form, which is the water-soluble form of the drug. And so if you think about it, when drugs move across membranes, regardless of the membrane, there's a difference in pH on one side of the membrane than the other. And we design drugs in such a way that when the pH is changed, they're able to better permeate that membrane. With the case of lidocaine, when there's inflammation that lowers the pH of the tissue, and the lidocaine doesn't work so well. That's why lidocaine works great on healthy tissue, and inflamed, infected tissue, lidocaine doesn't work so well with, because the pH changes the lidocaine into a form that does not penetrate the neurons. So most drugs are weak acids or weak bases because only small changes in pH are required to shift them back and forth between a lipid-soluble form, which easily passes through cell membranes, and a water-soluble form, which does not pass through cell membranes. And the water-soluble form of the drug is easily carried through the bloodstream. For those of you doing the calculus, all of that can be said best with the Henderson-Hasselbalch equation. The logarithm of the fraction of the concentration of the protonated drug, that R is just the variable group, that H stands for the proton, the hydrogen ion. And so the log of the protonated form of the drug, its concentration over the concentration of the unprotonated form of the drug, and the logarithm of that fraction of concentrations is equal to the pKa minus the pH. For all the rest of us, this will be fine right here. pH stands for the potential of hydrogen or the proton in water. A pH of 7 is neutral. A pH of greater than 7 is considered basic or alkaline, depending on whose pool you take care of. pH of less than 7 is considered acidic. And for all the rest of us, this is what's most important about all of that. Physiologic pH is about 7.35. Slightly on the alkaline or basic side. So drugs interact with receptors by means of chemical forces or bonds. That's why we talked about all that chemistry business at the beginning of the semester. And so most receptors are proteins which mediate the action of endogenous chemical signals. The reason that those keys and locks are in your body is for all sorts of regulatory processes. Being a human being is very complex. Being any living creature is very complex, requires all sorts of regulatory systems, and living biologic systems do that with locks and keys, receptors and molecules that stimulate that receptor. And so when we talk about receptors, we're talking about proteins, chains of amino acids that are there to mediate the action of chemical signals made by the body. So affinity is how tightly the receptor binds to the drug. When you take a key and you put it in a lock, you want the key to come out easily. It doesn't make any sense to stick the key in the lock and have it stuck there forever. Some drugs work that way. But most of the time, we don't really want the drug to fit that tightly. And so how tightly the drug fits to the receptor, how tightly the receptor binds to the drug, we call that affinity. Receptors are responsible for the selectivity of the drug action. And that means the lock is what's important, not the key. If you stick the key in the ignition of the car, it starts the car. If you stick the key in the trunk, it opens the trunk. If you stick the key in the glove box, it opens the glove box, and the story goes on and on. So it doesn't matter what the key does. What matters is what the lock does. And so it's the receptors, the locks that receive those keys, that decide what that drug will do. Drugs interact with receptors by means of chemical forces and bonds. If you remember, covalent means sharing electrons, and so a covalent bond is very strong and usually irreversible. If a drug makes a covalent bond on the receptor, that is usually permanent until that receptor is taken up by the body and metabolized. However, electrostatic bonds are pretty strong, not as strong as covalent bonds. There can be attraction of ionic groups, a positively charged ion with a negatively charged ion. Those two ionic groups are going to attract each other, so that's a way a drug can interact with a receptor. Hydrogen bonding occurs between either an oxygen and a nitrogen of one molecule and the hydrogen of another molecule, depending on how they're configured, and these are pretty strong bonds. We call these electrostatic bonds. However, the hydrophobic or lipophilic bonds are the ones that we're realizing are the most important in pharmacology. Fat things are attracted to each other and repel water. And so lipids are attracted to each other. We consider it a very weak bond, but certainly a very essential bond in the interaction between drugs and receptors. And then they talk about something called van der Waals forces, which are very, very weak atomic forces. They're so weak that they didn't even get a PowerPoint slide in the review. Maybe we'll bring that back. Well, here's two words that you ought to know in the pharmacology business: pharmacodynamics and pharmacokinetics. Pharmacodynamics is the action of the drug on the body. Kinetics is the action of the body on a drug. And so if we took propranolol, a beta blocker, we would say that's a beta adrenergic antagonist. It lowers blood pressure. That'd be an easy description of its dynamics, what the drug does to the body. Propranolol is metabolized and broken down by the liver, and the kidneys excreted by the kidneys. That would be pharmacokinetics, what the body does to the drug. So try to distinguish those two terms. And so an agonist is a drug that binds to and activates the receptor. It can open an ion channel or initiate a second messenger. Antagonists are going to bind to the receptor and prevent the activation of the receptor. So know the difference between agonist and antagonist. So an agonist is any drug that binds to a receptor and activates the receptor. I think we just said that. Oh, and here is a cartoon of an agonist. This is my phospholipid bilayer. My protein receptor is being activated by the agonist. The agonist binds to the receptor, and the receptor does some kind of chemical work in return. In many receptors, if the agonist leaves the binding site, it deactivates the receptor. And this is very common, and this makes sense. When the receptor is signaled by the activist, the receptor does the chemical process that is being signaled by the agonist. When the agonist leaves the receptor quits performing that chemical duty. But that's not always the case. Sometimes the agonist can cause a covalent change on the receptor and permanently activating the receptor. I've seen this trick question floating around on a few board questions, and so I thought I would at least throw that in. But the key here is that the agonist activates the receptor. So that brings us to a pharmacologic antagonist, which is any drug that binds to a receptor and prevents the activation of the receptor. And so here is my phospholipid bilayer, and here's an antagonist. It's a competitive antagonist in this case. Notice it binds to the receptor and does not activate the receptor. And antagonists we use a lot in pharmacology. And this is a competitive antagonist. It's a competitive antagonist because it competes with the agonist at the binding site. It does not allow the agonist to bind to the binding site of the receptor. So a competitive antagonist is any pharmacologic antagonist that competes with the binding of the agonist at the agonist's binding site, which is different than a non-competitive antagonist. A non-competitive antagonist is any pharmacologic antagonist that binds to the site on the receptor other than the agonist binding site. Receptors can have several binding sites. And so notice here, here's my receptor, and this non-competitive antagonist can bind to the receptor somewhere else besides the agonist binding site. And notice now it has deactivated the receptor. And so even if agonist comes along and binds to the receptor cannot be activated, or at least fully activated, because this non-competitive antagonist has deactivated the receptor. And so you'll see a lot of non-competitive antagonists in the pharmacology business because the agonist can't overcome the competition with a non-competitive antagonist. A chemical antagonist is very important. A chemical antagonist is a drug that binds directly to the agonist to prevent the agonist from working. So here's my chemical antagonist, and it's not going to bind to the receptor. It's going to just bind to the agonist and prevent the agonist from working. Protamine binds to heparin to prevent heparin from working. So protamine is a classic chemical antagonist. Digibind, digoxin FAB, is an antibody that binds directly to digoxin. So digibind is a chemical antagonist of digoxin digitalis. And they prevent the agonist from binding to the receptor site. Physiologic antagonist means the drug effect is completely opposite through completely different physiologic pathways. Our classic physiologic antagonist is epinephrine and histamine. Epinephrine causes vasoconstriction, histamine causes vasodilation, and they do that through completely separate physiologic pathways. So that's why they're called physiologic antagonists. I think I said this. The effect of a drug may persist long after the drug dissociates from the receptor. I wonder if this is my scrambled set of slides. It must be. Let's talk about natural curves. The interaction between a drug or a ligand is a fancy name for any type of chemical. And so the interaction between a drug or a molecule and its receptor can be described by a curve, just like everything in nature. Because drugs mimic the natural regulatory process, their effects follow natural curves. And so when we talk about drug concentration and response, response usually increases with increasing dose, but the more doses we give, the response decreases. And finally, there's some point where giving more drug results in no more response. So let's see, we have a curve of that. There it is. This is our classic agonist dose response curve. If we give a little bit of drug, we get a little bit of effect. We give more drug, we get more effect. And then eventually, if we give a lot of drug, we don't really get any more effect. We've reached the maximal effect. Half of the maximum effect, this would be the maximum effect up here of the drug. Here's our effect axis. This is our concentration of drug axis. And so the amount of drug required to get half of our maximum effect is called the EC50. That's the concentration drug. The ED50 is the dose of the drug. That's essentially the same thing. You'll see them written in different books. So the EC50 of the agonist dose response curve is the concentration of drug required to get half maximal effect. And so notice, give a little drug, get some effect, give a little more drug, get more effect, give a little more drug, and get half of maximal effect. Notice as we add more and more drug, we don't get such a dramatic increase in effect. Well, if we put competitive antagonist into the solution, our dose response curve looks like this. Because a competitive antagonist is in the solution, it takes more and more and more drug to eventually get maximal effect. And so basically more drug is required to get half of maximal effect when we add competitive antagonist to our agonist dose response curve. But this is the effect of non-competitive antagonist on the agonist dose response curve. Remember, non-competitive antagonist does not allow the agonist to fully win the competition. Notice in this situation, our agonist dose response curve, somewhere over here, right about this point, we can add enough drug to eventually win the competition and get maximal effect when we compete with a competitive antagonist. But if we add non-competitive antagonists to the situation, we can add agonist all day long. We will never get full maximal effect from that agonist because the non-competitive antagonist has deactivated the receptor. But the magic of this is that with non-competitive antagonist, the EC50, the dose required of agonist to get half of the new maximal effect remains the same. For those of you doing the rocket science. Most agonist dose response curves look like this when they are in a linear form. A linear form means each little space on our agonist concentration is equal to the previous space. But you might see them written as logarithmic agonist dose response curves with a logarithmic, let's say a logarithm of 10. Each little hash mark down on this axis is going to be 10 times more than the previous. So that might be 1, 10, 100, 1,000, 10,000, 100,000. So don't be surprised to see agonist dose response curves drawn like this, which are linear concentrations, or dose response curves drawn like this, which are logarithmic concentrations. And then you can use semi-logarithmic axes, meaning you don't have to use a log of 10, you can use a log of any kind of imaginary number and make these curves essentially linear if you want to, using a semi-logarithmic axis. But the point of this is you might see this, these two S-shaped curves unlabeled on some board question as if you know what all this means. And they'll ask you which one of these two curves has more potency. Potency means more effect is more effect from one drug at a lower concentration than another drug. So yellow would be like drug A and blue would be drug B. And notice we get more effect from drug A at the same concentration than drug B. So if we give this concentration of both drugs we get a little bit of effect from the blue drug, but notice we get a lot of effect from the yellow drug. And so this drug would have more potency because it can reach the same effect at a lower concentration. But here, the yellow drug has more efficacy. It has more effect. Notice the blue drug, it only has this much effect. It doesn't matter what the effect is. If you can plot it on a graph, notice the maximal effect of the blue drug is right here, but the maximal effect of the yellow drug is much higher, and so the yellow drug has more efficacy than the blue drug. I saw these curves. I was reading some board review preparation book, and the table was not titled. All of these graphs should have a title. Each axis should be labeled. The axis was not labeled. It just had two little S-shaped things on there, and they said this is an agonist dose-response curve. Which of these two drugs had more efficacy? And it is the one with more maximal effect. However, there are these things called quantal dose effect curves. Quantal means in segmented amounts. There's not some amount in between. So quantal dose effect curves implies some kind of on or off response to the drug. Either the effect is achieved or not achieved. And so, like treating ventricular fibrillation, you give a drug, a little bit of drug. We don't make the ventricular fibrillation go away a little bit. We give drug and give drug until the ventricular fibrillation stops. So the effect of the drug is either off or on. And that's what's implied with the simplest of quantal dose effect curves. So like I said, the EC50 is the concentration of drug required to achieve half the expected response. The ED50 is the dose of the drug required to achieve half the expected maximal response. So when you read books, some of them will talk about the EC50, some will talk about the ED50. They're essentially the same thing. TD50 is the dose of the drug required to achieve toxicity in half the subjects given the drug. They don't use toxicity in everybody because there's always somebody who's the last one standing. And so TD50 means that it is the dose of the drug required to achieve toxicity in half of the subjects given the drug. And they usually don't do this with humans. They usually do this with mice. And that goes for the LD50 as well. LD50 is the dose of the drug required to be low in half of the subjects given the drug. So if you're in an emergency room situation, you might find yourself looking up the LD50 of a drug to see if the dose of the drug taken can result in lethality. And this is usually measured in milligrams per kilogram, and again, it's usually tested in mice or rats. The half-life is the amount of time required to lower the concentration of a drug by half once medication has been delivered and fully distributed evenly. Then the drug level drops because it's being eliminated. And the T half is the half-life, the amount of time required to lower the concentration of the drug by 1/2. And so if the half-life is an hour, then after 1 hour, there's half the drug that was originally given. After that second hour, there's only half of that half, meaning 25% of the drug remaining from the initial concentration. The hour after that is only half of the remaining, so half of 25% is 12.5%. So don't be fooled. If a drug half-life is 1 hour, that doesn't mean the drug's gone after 2 hours. That means after 1 hour, half the concentration is gone. After the second hour, half of that concentration is gone. After the third hour, the half of that concentration is gone. That's how half-lives work. But for convention, we consider a drug to be completely eliminated by the body after 5 half-lives. So how the drug is administered affects its bioavailability, how available the drug is to the body. Bioavailability describes the concentration of systemic blood in relation to the amount of drug given, and that makes sense. Tissue of bioavailability is a little bit different. Tissue bioavailability describes the concentration of drug in the target tissue in relationship to the amount of drug given. So sometimes they'll talk about tissue bioavailability like lungs. Using an inhaler by delivering the drug directly to the lungs, we bypass the definition of bioavailability and increase tissue bioavailability to maximum by using an inhaler. So PO means by mouth. This is definitely an abbreviation you want to know. The thing to know about PO medications is the blood supply that goes from the gastrointestinal tract goes directly to the liver, and the liver will metabolize a majority of the drugs before they go into the bloodstream. So the bioavailability of PO medications, oral medications, is rarely 100%. Usually most of the drug that's given by mouth is metabolized away, resulting in only about 10% of that drug, anywhere from 10 to 50% on average of drugs taken orally get past the liver and into the bloodstream. IV drugs, intravenous, the drug goes directly into the bloodstream when we give IV drugs, and so the bioavailability by definition of IV drugs is 100%. IM means intramuscular, into the muscle. We inject the muscle, or we inject the drug directly into the muscle, and then the muscle slowly releases the drug over time. And so that's the way we give IM. That's the purpose of giving IM medications. SC means subcutaneously, which means it's given under the skin instead of the muscle slowly delivering the drug. The fat tissues under the skin slowly deliver the drug over time. PR means by rectum, and this, something to keep in mind about drugs that are delivered rectally is that blood also goes to the liver first for processing. So most PR drugs do not have 100% bioavailability, but this is a superior route to use when something needs to be given quickly, there's no IV source, and the oral route is not available. Like Diastat is Valium, and it can be given PR in people who are having seizures. Inhalation, inhaler, means the drug is delivered directly to the lungs, and so that improves tissue bioavailability to the lungs. And then some inhaled drugs can be delivered to the drug, can end up in the bloodstream after inhalation, but most inhalers are used to deliver the drug to the lungs. Transdermal, please do not confuse transdermal with topical. Transdermal means we apply it to the skin and the drug crosses the skin to get into the systemic blood supply, like nicotine patches or duragesic patches that have pain medication in them, or estrogen patches that have estrogen in them. We put them on our skin. The drug crosses the skin and ends up in the blood supply to work on the body. That's how transdermal works. Topical means it's applied to the mucous membranes or the skin, and that is where the action is intended locally at the site of administration. And so if we get a bug bite and put some hydrocortisone on it, that's topical because we're placing it on the skin where we want the site of action to occur. Intranasal means it's injected into the nose, and this is a way to deliver drugs to the nasal mucosa or even across the nasal mucosa into the bloodstream, and then the area of this part of the face drains into the base of the brain, and so we can deliver drugs to the pituitary that way as well. Intrathecal means into the cerebrospinal fluid. This can either be done through the foramen magnum, the hole in the back of the skull. This can be done by injecting it into the cerebrospinal fluid surrounding the spinal cord. Epidural means outside of the spinal dura. This is the way some people do spinal anesthesia. They will inject a medication that decreases pain sensation, and they'll inject it right outside of the spinal dura. That's what epidural means. Intra-articular means into the joint spaces, and so people who get steroid injections into things like their knee, those are intra-articular injections, and so that means we get complete bioavailability of the drug into the joint space rather than expecting the drug to be carried to the blood supply and delivered to the joint space. Something to keep in mind is the first pass effect when drugs are taken orally or really by any route. The liver especially will metabolize those drugs away, and that's the first pass effect because the liver will metabolize many drugs before they enter the systemic blood supply. Which brings us to prodrug. Prodrugs are drugs that are inactive until the body converts them into their active form. And most of the time we're talking about the liver. We're talking about drugs that can be taken orally. They'll be inactive until they pass through the liver, and the liver will activate them into their active form through the normal processes of the liver. Not all prodrugs need to be activated by the liver, but the near entirety of them do. So drugs that are inactive until they make their first pass through the liver and become metabolized into their active forms, we call those prodrugs. And this is a very important modern strategy in pharmacology. And so permeation means penetration of drug into the tissues. We should have put these slides earlier. There are all sorts of ways to get permeation and get the drug across the membrane. Aqueous diffusion, if the drug is water soluble and small enough, it can get across the membrane through aqueous diffusion. Lipid diffusion, the gaseous anesthesias, ethanol, ethyl alcohol gets across the membrane by lipid diffusion because they are very lipid soluble. And then we have special carriers. If you remember, there's all sorts of molecules that carry carry amino acids and carry glucose across the membranes. And then there's endo and exocytosis, little parts of the phospholipid bilayer can break off and make little packets and pull drug in or push drug out of the cell through endocytosis and exocytosis. Transformation is the chemical changing of the drug by the body. When the liver metabolizes drugs, we call that transformation. When the liver metabolizes anything, we call that transformation. Liver transformation is the most important form of drug transformation. However, there is peripheral transformation. Enzymes in the bloodstream, enzymes anywhere in the body can change and break down drugs. Gastrointestinal transformation is also important in drug transformation as well. We take a drug orally. When it crosses the gastrointestinal tract to go into the portal blood supply, the gastrointestinal tract can metabolize the drug and transform it. Phase 1 reactions in transformations are called oxidations. And so phase 1 involves conversion to a water-soluble metabolite by adding some kind of oxygen or oxygen-like group to the molecule, making it more water-soluble. And this is done by the cytochrome P450 enzyme systems. Phase 2 reactions are called conjugations. Oxidations are just adding a single oxygen group, single hydroxide group, something along those lines to make the drug more water soluble. Conjugation means a big molecule is taken, big water soluble molecule similar to glucose is taken and added to the molecule to make it very water soluble. Bilirubin is a natural breakdown product of hemoglobin and is very toxic and very lipid soluble. And so your liver conjugates the bilirubin. It takes something similar to a glucose, a big glucuronide, and attaches it to the bilirubin to make the bilirubin very water soluble so it can pass out into the kidneys, into the urine. And so the liver does this with drugs as well. Conjugates, meaning taking a big molecule to make the other molecule, attaches it to the other molecule to make it much more water soluble. And so elimination is the removal of drug from the body. Yes, we are playing scrambled slides today. So there is renal versus hepatic elimination. Not all drugs need to be transformed by the liver to be eliminated. Urination, drugs can be eliminated by the kidneys through urination. And then drugs can be passed into the bile and be passed through the stool, and that's hepatic elimination through the bile. A majority of the drugs that you come across will require both renal and hepatic elimination. The volume of distribution is the amount of drug in body relative to the concentration of drug in the blood. And so if we give drug and it all stays in the bloodstream, that's a small volume of distribution. But if we give drug and it's absorbed by the rest of the body out of the bloodstream, like into the fat spaces and absorbed completely out of the bloodstream, that would be a very large volume of distribution. And the volume of distributions of drugs can be much, much, much larger than the actual volume of compartments in the body. So don't be surprised because it's a theoretical number. So the volume of distribution of a drug that's completely absorbed out of the bloodstream can be just as high as 500 liters in that neighborhood. And so I don't have the long explanation for that today, unfortunately. Clearance is the elimination of drug in relationship to drug concentration. And so I get a lot of questions about this that go unanswered. A drug can be eliminated in relationship to the drug concentration. That means the more there's drug, the more the body can eliminate it. The more drug means more elimination. And that's first order kinetics. That means that the more drug there is in the body, the more the body can eliminate it. However, that system can be saturated. There can be more drug than there is the body's ability to eliminate it. And then it has a fixed rate of clearance, and that's considered a zero-order kinetics. So when there's so much drug that the body's ability to eliminate is fixed, then that's considered a zero-order kinetics. Once the drug concentrations are low enough, that means the higher concentration of drug, the more drug there is in concentration, the more it's eliminated. As the drug decreases, the rate of elimination decreases. That's first-order kinetics, first-order elimination. Someday we'll animate all that. And so whenever drug doses are repeated, the drug will accumulate until the dosing stops. That makes sense. When we give drug doses repeatedly, the drug concentration in the body should go up. If the dosing interval is shorter than 4 half-lives, and so if we give a dose of a drug and before the 4th half-life, when it's considered completely eliminated or nearly eliminated, if we give another dose, then we can expect drug accumulation to occur. Which brings us to the maintenance dose. When we try to calculate a maintenance dose, that means the dosing rate is equal to the clearance of the drug times the target concentration. The best way to describe a maintenance dose is an azithromycin Zithromax Z-Pack, the drug you take 2 on the first day, that's the loading dose, and then you take 1 a day after that. That's the maintenance dose. With IV drugs that require very careful calculation, very careful drug levels, our dosing rate is easily calculated by multiplying the clearance with the target concentration, the concentration we're trying to achieve. And hopefully this is my last slide. The loading dose is like that big dose that we give at the beginning to get us up to the target concentration quickly. And so the loading dose is quite simply equal to the volume of distribution. That's why we use volume of distribution as a calculation, because it comes in so handy for all sorts of pharmacologic calculations. And so the loading dose, for those of you doing the math, is equal to the volume of distribution of the drug times the target concentration, the amount of a drug we are trying to get in the body. Well, that is certainly enough for one semester.
This is Cable 55, UH Maui College Television Network.